Morning. The committee will now come to order. The committee is meeting today to hear testimony on the impact of the end of Medicaid funding for the insular areas under the Affordable Care Act, also known as the Insular Areas Medicaid Cliff. Under Committee Rule 4F, any oral opening statements at hearings are limited to the chairman and the ranking minority member. Therefore, I ask unanimous consent that all other members' opening statements be made part of the hearing record if they are submitted to the clerk by 5 p.m. today. I ask unanimous consent that the gentlewoman from the U.S. Virgin Islands, Ms. Plaskett, be allowed to sit on the dais and question the witnesses. No objection. Hearing no objection, so ordered. Good morning again, everyone. The Mariana Islands, which I represent, and the 4 other U.S. insular areas all face a Medicaid cliff at the end of this year. Supplemental funding for the Medicaid programs in our areas, included in the Patient Protection and Affordable Care Act, or Obamacare as we like to call it, expires this year. And I can just recall as if it was only yesterday when Pedro Pierluisi and I enlisted the help of the Congressional Hispanic Caucus and met the president on this issue. And Senator from New Jersey joined us, and that's, I think, from that meeting, we were able to get this money because we were not included in the Affordable Care Act under the reconciliation budget process. But loss of that funding puts healthcare delivery at risk, not just for Medicaid recipients in our islands, but for the population at large. Today's hearing is meant to shine a light on that imminent crisis. I want to thank the directors of each of the Insular Area Medicaid programs for being here today as witnesses. Your programs are already short of cash, so the cost of coming to Washington was not taken lightly, I know. But I think that we could have no better spokespeople to describe how truly dire the situation is. I hope we will be able to learn from you what the loss of Medicaid funds will mean to the people you serve, real people, our people, who simply have no other means of getting basic health care. Also invited to testify today is the Chief Executive Officer of the Commonwealth Healthcare Corporation. Ms. Esther Muña runs the one and only hospital in the Marianas, and that hospital depends on Medicaid for over 1/4 of its revenue. I hope Ms. Muña will be able to tell us what the loss of Medicaid funding will mean to the hospital's ability to deliver services and how that will impact not only Medicaid patients, but all her patients. I think Ms. Muña's description of how the hospital depends on Medicaid revenue will help us understand how losing Medicaid revenues will hurt healthcare providers in private practice as well. So we are all working from a common set of facts. Let me quickly review the situation. In the states and the District of Columbia, Medicaid is an entitlement program. To the extent there is a need for services, and to the extent a state can provide local matching fund, federal Medicaid funds are always available. In the 5 insular areas, this is not the case. Up until 2011, we each received a fixed block grant. That block grant, I am sorry to say, is unrelated to the need of each of our areas. It seems to have been set rather arbitrarily decades ago. And the local match to access that block grant was set in law at 50-50. 50-50 is the same matching rate as the wealthiest states, while states as poor as the insular areas only match at a rate of 24 local, 76 federal. Obamacare provided some relief, an extra $7.3 billion in temporary Medicaid funding, and a permanent change in the match to 45 federal, 55 local. But the Obamacare money is no longer available after this year, and all the insular areas will revert to their block grants. Using 2018 data for American Samoa, that means going from $20 million in federal funding to $12 million. For Guam, from $56 million to $18 million. For the Marianas, from 25 million to 7 million. For the U.S. Virgin Islands, from 70 million to 18 million. And for Puerto Rico, from 2.3 billion to just 360 billion. You cannot suffer cuts like that and continue to deliver services. The path forward is unclear. Certainly more money is needed and an equitable matching rate. But there's also the need for each of the insular areas to build capacity to deliver care. Because ultimately, the goal is not just to have the same funding as states. What we want is medical care for those who need it in the insular areas to be every bit as good as medical care in the states. So I look forward to hearing from the witnesses for their advice and experience. Lastly, I want to report that one of the meetings we arranged for the directors to add value to their time in Washington has paid off. Some of you already know this prior to coming here. But you met yesterday with staff of the Senate Finance Committee and the House Energy and Commerce Committee. We also arranged for you to meet with administration officials at CMS, the Centers for Medicare and Medicaid Services. You asked them at the meeting to allow for Obamacare Section 1323 money to be used in fiscal year 2020, be used before you use the Section 1108 annual block grant. I received word last night that CMS has decided to do what you asked. That will make more money available that otherwise would have been lost. So if we're able to do nothing else, your trip here was rewarded. I would like to say that we will get something else done here. But I certainly do believe that your trip here and today's hearing will have positive results. And I now recognize my colleague, the gentle lady from Puerto Rico, for an opening statement.
Thank you, Vice Chairman, and I really appreciate this hearing taking place. I want to thank all for being here today to discuss one of the most important and critical issues currently affecting all the U.S. territories, the impending expiration of the additional Medicaid funds granted by the Affordable Care Act and the accompanying instability of our healthcare infrastructure. In 2017, 1.6 million Americans living in the territories were enrolled in Medicaid. That breaks down to 79% of the population of American Samoa, 21% of the population of Guam, 33% of the population of Northern Mariana Islands, and 47% of the population of Puerto Rico, and 16% of the population of the U.S. Virgin Islands. The national average enrollment for the states and the District of Columbia was 21%. During the same year, the Medicaid program spent an average of about $1,800 a year per territory enrollee, in contrast to the national average, excluding the territories, that was more than $7,000 per enrollee. Medicaid in the territories is subject to statutory federal matching percentage, what we call FMAP, and the FMAP for the states varies annually relative to each state's per capita income. The FMAP for the territories, however, is completely different. We are permanently capped by law to 55%. If the formula used to determine the FMAP for the states were applied to Puerto Rico, the federal funding match share will be increasing up to 83% program maximum. For the 50 states and the District of Columbia, Medicaid provides a guarantee of federal matching payments with no preset limit. And this is the main difference between the treatment to the territories and the rest of the states. However, annual federal funding for Medicaid in the territories is subject to this statutory cap. Once a territory exhausts its capped federal funds, it will no longer receive federal financial support for its Medicaid program during that fiscal year. In 2011, the Affordable Care Act granted the territories an additional $8.25 billion in federal funds for their Medicaid programs in lieu of establishing a healthcare insurance marketplace. The additional funding for each territory ranged from $109.2 million for the Northern Marianas, $6.3 billion for Puerto Rico, and was available to be drawn down between July 2011 and September 2019. Since 2011, federal Medicaid spending in Puerto Rico has exceeded the statutory cap by using the funds available under the Affordable Care Act. These funds were depleted in February of last year. During the last Congress, 115 Congress, the President and Trump acted to avert this crisis in Puerto Rico Medicaid's program with a temporary increase of the federal cap to $296 million for the fiscal year 18-19 in the Consolidated Appropriations Act of 2017. Moreover, as a result of the state of emergency caused by the Hurricanes Irma and Maria in 2017, we again increased the federal cap to $4.8 billion for the first time, 100% federal cost share to the fiscal year 19 to keep Puerto Rico Medicaid program operational. All these additional sources of federal funding for Puerto Rico in Medicaid program will expire in September of this year. For my island, Medicaid cap set by statute in the fiscal year 2020 will be approximately $375 million, with no additional source of federal funding available. This means that Puerto Rico will exhaust its federal Medicaid allotment in the first 3 months of fiscal year 2020 and will bear the expense in excess of 85% of the federal program, placing additional pressure on sparse territory resources. And I know this is going to be happening in all territories as well. Each territory is affected by this inequitable treatment in healthcare funding in their own way. However, all of our Medicaid programs, as currently conceived, are unsustainable. This underfunding contributes to larger systemic problems, including lower provider reimbursement rates and provider shortages. To correct this challenge, I have introduced H.R. 2306, the Puerto Rico Medicaid Act, which seeks to strengthen the Medicaid program on the island by increasing the cap and removing the statutory FMAP limitation. I'm also an original co-sponsor of H.R. 1354, the Territories Health Equity Act, legislation introduced by Congresswoman Plaskett of the Virgin Islands that addressed to face this problem for all 5 territories. Both bills are currently under the jurisdiction of the Energy and Commerce Committee, and I will continue to work with my fellow delegates and the members of that committee to advocate for the advancement of those bills. I trust that today's testimony will help my colleagues understand the urgent need of action. If we fail to act with the expediency that the situations require, the provision of health care in all territories will be severely affected by far-reaching repercussions for the rest of our nation. Although I recognize that this is not the committee with jurisdiction, I would like to thank Vice Chairman Sablan and members of this committee for this important hearing, having the witnesses to testify and to be on the record on the impacts of the Medicaid cliff that will undoubtedly help us as we continue working for a long-term solution of this issue. Thank you, Chairman.
I thank the gentlelady for her opening statement. I now recognize the chairman of the full committee, Chairman Raul Grijalva.
Yeah, thank you very much. No opening statement, Mr. Chairman, just to thank you for organizing the meeting. I think an excellent panel, and I'm here to learn something and which direction we're going to go in terms of dealing with this issue. So thank you very much, Mr. Chairman. I appreciate it. You know, I was just commenting to Mr. Lowenthal here, Chairman Earl, that, you know, when you're chairman of a full committee, Mr. Sablan, you're always a little conscious, whether people say it or not, that of a possible coup where your power is removed and you're thrown off the chair. And having said that, Mr. Sablan, of all the people, Mr. Sablan, I just can't believe it, you know? With that, I yield back.
Thank you. Thank you for those. I'm going to have to analyze those comments, but I think he meant well. And thank you. I would now like to introduce our witnesses. Ms. Esther Lizama Muña, who is the Chief Executive Officer of the Commonwealth of the Northern Mariana Health Care Corporation. Ms. Muña, again, runs our only hospital in the Marianas, and whose revenue is about 1/4, if not more, of the comes from Medicaid patients. Ms. Helen Castro Sablan, who is the director of the Commonwealth of the Northern Mariana Islands State Medicaid Agency. Welcome to the two of you. I'm going to go ahead and also acknowledge Ms. Teresa Arcangel. Did I say that right? Huh? Archangel. Okay. Who is also is the chief administrator of the Guam Division of Public Welfare, which runs the Medicaid program. And I would like to ask Ms. Radiwagan to introduce her witness.
Thank you, Mr. Chairman. Our Medicaid Director and CEO is Chief Tofui Taufa Sandra King Young, and she came into the position of CEO and Director of Medicaid. She's been there for most of the time that the ACA funds have been there, and she's been working very hard on it. And I want to welcome her to, and her delegation to town.
Thank you. And now I'll recognize the ranking member for introduction of her.
And thank you, Mr. Sablan. I would love to introduce Ms. Angie Avila. She's the Executive Director of the Puerto Rico State Health Insurance Administration. Actually, we held a panel yesterday, and she's the one providing the data related to our healthcare system in coordination with the Secretary of Health in Puerto Rico, Mr. Rodriguez.
No. All right, and I'm Ms. Plaskett. I recognize Ms. Plaskett to introduce the witness from the United States Virgin Islands.
Thank you, Mr. Chairman. It's an honor and a pleasure to be here under your leadership, Mr. Grijalva. I have you note that I call the leadership of this subcommittee for Mr. Sablan, so please be careful.
Change that.
This is a really important issue, and I'm really grateful to have Ms. Michael Reimer Brown, who's the Assistant Commissioner of the United States Virgin Islands Department of Human Services, which does tremendous work and is managing this issue as well. I do note that the governor has his chief of staff here, as well as other members of the administration are here, because we recognize, and our governor, Governor Albert Bryant, recognizes what a tremendously important issue and the need for this funding is to the people of the Virgin Islands. Thank you.
Well, thank you, everyone. And again, witnesses are welcome. But under committee rules, oral statements are limited to 5 minutes, but your entire statement will appear in the hearing record. The lights in front of you will turn yellow when there is 1 minute left, and the red, and then red when your time is expired. I like to keep time frame. We may, if necessary, do 2 rounds of questioning, but the moment we'll start with Ms. Esther Muña, please.
Chairman Grijalva, Ranking Member Bishop, Vice Chairman Sablan, and distinguished committee members, thank you for the opportunity to appear before you today. As Chief Executive Officer, I oversee the work of the Commonwealth Healthcare Corporation, known as CHCC. CHCC is responsible for CNMI's sole hospital, dialysis services, mental health, public health services, and several outpatient clinics on Saipan, Tinian, and Rota. As one born and raised on Saipan, I relied on our healthcare services long before I became responsible for them. I've seen how being in a remote location poses a host of challenges for our population. For example, in the 1990s, a baby with a congenital heart disease had to take a total of 8 hours in flight time to receive care costing $1 million accumulated in a year. Several residents that are my neighbors, my relatives, and my friends are unable to return home to the CNMI because we do not have an oncologist on island to manage their complex cancer treatment. A gentleman with a neurological injury waited for days before being transported off island because the cheapest and safest way for him to receive treatment for his injury was at a hospital in the Philippines, and like many US citizens, did not own a US passport. Patients with complex medical issues like this gentleman are often flown to Guam, Hawaii, the Philippines, and Taiwan in order to receive care. In addition to these challenges with access to care, delivering health services in a remote island is more costly with high costs of shipping, and we are competing with U.S. hospitals for the same workforce. 15 years ago, with only the capped and inadequate Medicaid funding and the CNMI undergoing a major economic crisis due to several global and U.S. federal policy shifts, the hospital struggled to stock medical supplies and recruit healthcare workers. The 2007 CMS survey revealed many problems. With no funding improvements, paydays were missed, doctors and nurses left the island. In September 2012, CMS issued a termination notice to our hospital. It was clear that without adequate funding, the CHCC could not sustain life-saving services, much less the healthcare needs of our residents. The $100 million available to the CNMI through supplemental Medicaid funding in 2011 gave us the chance to deliver a little more than basic healthcare services that our people deserve. Prior to 2011, we were receiving the leftover crumbs of the capped funding since the insufficient Medicaid funding was desperately needed and was utilized to save the lives that were going off island. With the supplemental Medicaid funding, the CHCC accepted a payment methodology that allowed the hospital to be paid at 55 cents of its $1 cost because the CNMI government's declining economy could not afford to make the match of the 45 cents. It wasn't the most ideal funding. However, if it were not for that boost in Medicaid funding that supplemented that statutory cap, we may have lost our hospital, and I wouldn't be here before you today. Thanks to the steady Medicaid reimbursements, my team has brought the hospital operations to the highest level that it has ever been. With increased revenue, we've implemented an electronic health record system, a quality assurance unit, outpatient pharmacy, telemedicine services, added specialty services such as podiatry, ENT, orthopedic surgery, and as of this month, oncology. We have tripled our medical staff with clinic visits nearly doubling since 2013. We have cut our readmission rate in half, far below the national average. We did this by maximizing efficiency and innovation to maintain U.S. hospital standards in our remote rural environment. During two of the worst storms in U.S. history, we ensured uninterrupted patient services while bringing medical attention directly to the villages that were hit hard by the storms. The reliable monthly reimbursements from Medicaid protected CHCC's cash flow and enabled our staff to do their jobs. We took full advantage of the opportunity presented to us in 2011 to stabilize our healthcare system. So with the heels of Typhoons Yutu and Mangkhut, we face another crisis. Our Medicaid program is unable to sustain the needs of our healthcare system. Earlier this year, the program exhausted the federal funds made available in 2011. A return to the low statutory cap on federal contributions and the low fixed federal share endangers the very existence of our healthcare system, threatens to further erode our economy, and puts at risk the health and well-being of our people. Help us maintain our progress and avoid a return to those dark days. Stabilize our Medicaid funding, and provide equity to the U.S. citizens in the CNMI. Thank you.
Perfect timing, Ms. Munya. Thank you for that. We're trying to get our witnesses to testimony, and then because some members will need to run to vote. But Ms. Sablan, you're recognized for 5 minutes.
Honorable Chairman Grijalva, Ranking Member Bishop, Vice Chairman Sablan, members of the Committee on Natural Resources, thank you so very much for holding a hearing on the Insular Areas Medicaid Fiscal Cliff and for providing the Commonwealth of the Northern Mariana Islands the opportunity to present information on what the fiscal cliff means for the U.S. citizens of the CNMI. We recognize that we are the smallest of the U.S. territories in terms of population and geographic size. Nevertheless, the CNMI and its U.S. citizens value their U.S. citizenship and the Medicaid program. The CNMI Medicaid lives under Section 1108 budget caps that are totally inadequate. The ACA recognized the problem and temporarily adjusted the budget caps. The federal medical assistance percentage was also adjusted to 55-45%. When calculations give the CNMI income will be higher than all states. What does that mean for the CNMI today and tomorrow? In fiscal year 2018, the CNMI Medicaid program expended over $53 million to provide care for the 15,138 eligible Medicaid populations. Today, the number of enrolled Medicaid beneficiaries has increased to 16,206, following the two typhoons in 2018, including the Category 5 Super Typhoon U2. In March 2019, the Sinamay Medicaid program completely exhausted its Medicaid program funding in the final amounts made available through ACA. The Sinamay is not at physical cliff, but it is in free fall. For fiscal year 2020, Region 9 has informed us that our allotment will be $6.85 million for MAP and $11.2 for CHIP. This is not much of a change in the cap and means that the shortfall between the actual Medicaid expenditures for fiscal year 2018 and CMS fiscal year 2019 allotments will be allotted $50 million. Will be around $50 million when the accounts payable for 2018 and fiscal year 2019 are accumulated. The median income for a family of four, based on data provided by U.S. Census in 2010, shows that the Sinamay family earned $19,958 in the same year that the average U.S. family earned $61,564. If we just step back for a minute and think about just this basic information, we can clearly understand why so many residents in the Sinamay rely on Medicaid for health care or uninsured. The more than 16,206 individuals in the Medicaid program constitute 46% of the U.S. citizens in the Sinamay. The Sinamay government, the Medicaid program, and its beneficiaries and the Sinamay health system is in a dire situation following the end of additional funding provided under the ACA and the devastating impacts of Typhoon Mangkhut and Super Typhoon U2 in 2018. I am here to plead the U.S. Congress to provide Medicaid disaster assistance and to address the inequities in the Medicaid program for the territories. I have worked in the Sinamay Medicaid program since 1986, over 32 years ago. In all these years, I've never been more emotionally affected than I have in the past year. We are currently in the process of severely curtailing services, limiting choice of providers in the program, and are making decisions knowing full well the adverse short and long-term consequences our decisions will have. I am frightened and saddened at each step in our undertaking because I understand the effects on our people and our health system. While we are doing our very best to determine what might be intellectually characterized that is so-called best interest given the limited resources. Decisions regarding what services should be continued, what should be curtailed or dropped, and what providers can be paid are and will continue to be made. It is very hard to explain to those that come to our office asking whether the health services that they're receiving will be cut. It is very hard to listen to their stories. What should we do with a patient that has been in an off-island hospital in another state that may be dying? Should we now inform the patient and parents that we are sorry, but we will no longer pay for any of their medical bills? It is impossible for me not to see the faces of the people behind the numbers and impact that each decision made will have. In summary, the Sinamay is desperate and desires situation, and the U.S. citizens in these islands deserve equity in health care. As such, we're humbly pleading for the U.S. Congress to please help to treat this equitably, and if I may humbly ask quickly. Thank you once more for taking the time to hear this issue.
Another perfect timing witness. Thank you very much, Ms. Sablan. At this time, I'd like to recognize Ms. Teresa Archangel for her 5 minutes, please.
Half a day, Mr. Chairman and ranking minority members. For the record, my name is Maria Teresa Archangel, Chief Administrator for the Division of Public Welfare, Guam Department of Public Health and Social Services. I oversee Medicaid administration. I'm here with Ms. Linda Denorsi, Director of the department. On behalf of Governor Leon Guerrero and the people of Guam, we thank you for inviting us to testify regarding Guam Medicaid financial issues. The cost of providing healthcare in Guam is quite high due to its geographic location, the lack of tertiary centers, and other healthcare professionals. Some medical providers refuse to accept Medicaid patients due to delayed payments. This further increases the medical costs because recipients are forced to seek treatment at the hospital emergency room. Additionally, the cost of drugs is more expensive in Guam compared to the U.S. mainland because there are only 5 to 6 wholesalers that ship drugs to Guam in comparison to the hundreds of companies available here. These vendors may tend to impose a higher price due to lack of competition. The shipping cost and the risk of stocking drugs that have limited shelf life also contribute to this high cost. Guam has been burdened for years by U.S. treaty obligations with Compact of Freely Associated States, which allows unrestricted immigration. These immigrants have contributed to the changes in Guam's demographics. In FY 2017, Guam estimated that nearly $147 million were spent on education, public safety, healthcare, and social services for these migrants. Of that amount, $38.5 million was for healthcare and welfare services. Guam's economy is heavily dependent on tourism industry and U.S. military spending. The influx of COFA migrants created an additional hardship on Guam's economy. As a result, the government is unable to guarantee the availability of local matching funds to draw down the federal grant awards. The Guam administers Medicaid under federal regulations that are different from the 50 states and the District of Columbia. Guam Medicaid's federal medical assistance percentage is fixed at 55%. In addition, the federal Medicaid funding to Guam is subject to an annual funding cap, which is $17.97 million for this fiscal year, unlike the states and the NDC that are open-ended. Furthermore, beginning in 2014, the federal government funded the states that implemented ACA Medicaid expansion for childless adults at 100% of the coverage cost for the first 3 years. This is not applicable in Guam. Instead, Section 2005 of ACA provided Guam with $268 million, which partly alleviated the financial shortfall not only of our Medicaid program, but also of Guam's locally funded medical assistance program, where most of the COFA citizens qualify. This funding allowed Guam to shift the cost of COFA migrants' emergency services to Medicaid. But the 45% required local match provides hardship in fully expanding the program to cover more uninsured population. Unfortunately, Guam would not be able to expend all the ACA funding, which will expire this fiscal year. If ACA is not extended or replaced, the Guam Medicaid could be forced to decrease its income guideline and terminate some of its program eligibles. This will further increase the uninsured population in Guam. The U.S. territories receive fewer federal dollars for low-income healthcare programs than the U.S. states due to long-standing regulations. There should be no disparity on the Medicaid funding distribution. The low-income U.S. citizens in Guam and other U.S. territories are no different from the U.S. citizens in the mainland, and so their healthcare benefits and needs should not be viewed or treated differently. Hence, Guam proposes to remove the expiration date of funding appropriation under Section 2005 and 1323 of ACA until it's fully expended, remove the Medicaid cap, and increase the FMAP of Guam and the other U.S. territories. We applaud the committee for this oversight and for taking the necessary steps to evaluate the needs of Guam and the other territories. Thank you for the opportunity to speak regarding this important issue.
Oh, thank you, Ms. Archangel. Perfect timing again. I appreciate your coming here and testifying. I would like to now recognize Ms. Michael Reimer Brown. Did I get that right, Ms. Brown?
McCall.
All right, okay, you're recognized for 5 minutes.
Chairman Sablan, Ranking Member Bishop, and members of the committee, thank you for the opportunity to provide testimony on the significant impacts to our healthcare system and the people of the United States Virgin Islands in light of the impending Medicaid fiscal funding cliff, which will impact us on beginning October 2019. I am McCall Reimer Brown, Assistant Commissioner of the Virgin Islands Department of Human Services, and I have direct oversight of the Medicaid Division. Accompanying me today is Mr. Gary Smith, our Virgin Islands Medicaid Director. I must also thank Kimberly Causey Gomez, Commissioner Designee of the VI Department of Human Services, who has extended to us her complete support as we prepare to come to this important committee meeting today. On behalf of the Honorable Governor Albert Bryan Jr. and the more than 100,000 American citizens living in the U.S. Virgin Islands, we bring you greetings, and as we say in the Virgin Islands, a pleasant good morning. As a people, we want to convey our heartfelt gratitude, appreciation, and thanks for the concern and the support that you and your colleagues in Congress have provided as we continue to recover from the unprecedented damages caused by Hurricanes Irma and Maria, two Category 5 hurricanes which ravaged the Virgin Islands in September of 2017. We are a resilient people, but my testimony today is truly intended to actualize the empathy. I appear before you today to request your continued urgent support to address the critical federal and local funding crisis we are facing in our healthcare system. On September 30th, 2019, by that date, we are currently projecting we will have fully expended the additional $142.5 million in federal medical funding provided under the BBA. Members, with no exaggeration, the Congress, together with the administration, must act by September 30th, 2019, to avert catastrophic damage to our healthcare system. At that point, the federal Medicaid matching rate will revert back to the statutorily mandated 55% matching rate for most of our Medicaid programs, and the federal Medicaid funding cap of approximately $18.8 million. This is not sustainable given the current state of our Medicaid program. If the Virgin Islands only receives the statutory cap amount of $18.7 million at the 55% rate, that funding is projected to only cover 26% of the federal funding needed during the fiscal year. We believe that there needs to be a permanent statutory fix that addresses the unfair and disparate treatment all territories face in their Medicaid programs along the lines of H.R. 1354, the Territories Health Equity Act, introduced on February 25th, 2019 by our delegate, Stacey Plaskett. We are requesting that Congress and the administration work with us to support the following 5-year Medicaid funding request. We are requesting 100% federal Medicaid matching rate be extended to the U.S. Virgin Islands for 2 additional federal fiscal years, and we are currently projecting that at least $251.5 million in additional federal Medicaid funding be provided during this period, as was done in the BBA 2018. Secondly, we are requesting at least an additional $377 million in federal Medicaid funding based upon our current projections in lieu of our annual Medicaid cap be provided to the U.S. Virgin Islands. Unless the Congress and the administration act to support the 2 requests I have outlined above, before September 30th, 2019, we will be faced with potentially catastrophic damage to our Medicaid program and our healthcare system, to include having to remove upwards of 15,000 individuals from our Medicaid program who still need healthcare services, and having to deny men, women, and children and infants who need to be transferred to the U.S. mainland for care not available. We want to thank you for the opportunity for being here today, and we strongly urge that we are considered for additional funding going forth in the next fiscal years. Thank you very much.
Wow, thank you, such wonderful witnesses. I love you all. And so thank you again, Ms. Reimer Brown. I'd like to, at this time, recognize Ms. Sandra King Young, who's actually this is not her first appearance. She's been here before. So, Ms. Young, you have 5 minutes, please.
Good morning, Chairman Sablan, Ranking Member Gonzalez-Colon, and honorable members of the committee. I bring to you greetings from our Governor Lolo Matalasi Molinga and our Lieutenant Governor Lemanu Peletimaunga, and thank you for this important hearing to provide information on the impact of the September expiration of the Medicaid funding for American Samoa and our sister territories. My name is Sandra King Young, Medicaid Director for American Samoa. My written testimony submitted for the record to the committee outlines the devastating impact of the loss of the ACA funds that American Samoa has not been able to spend and the reasons why, so I will not reiterate those points here. At the outset, I want to point out again that for American Samoa, Medicaid is our only health insurance plan available to the public at large. Insurance carriers have historically declined to provide health insurance to our people because we are a high-risk and very sick population with one of the highest rates of obesity and non-communicable diseases in the world. And we are a very poor community. Without Medicaid, our people will have no health insurance coverage, and our healthcare system would face an absolute collapse and insolvency. Medicaid is our people and our territory's lifeline for medical care services. As we have repeatedly shared, the two biggest challenges with our Medicaid program are our government's inability to fund the local match requirement for the Medicaid program. Second, the statutory capped annual funding or block grants placed on the territories prohibits us from fully executing the benefits requirements under our state plan and the Social Security Act. Because we have exhausted our local match for this fiscal year, as of today, our Medicaid agency has suspended all referrals of any new off-island patients to New Zealand. We have suspended any new payments needing wheelchairs or other durable medical equipment, including prosthetics. And we are cutting back on copay assistance to our Medicare dual-eligible population. Our hospital, however, continues to receive its Medicaid funding under the ACA because it does not need local match dollars under its certified public expenditure payment method. Oftentimes, when we try to explain why we need the relief from local match and why we cannot spend all of our ACA Medicaid dollars, I think people nod their heads, but they don't really know what that means to a patient's life, to their family, or to our community. The real-life stories of life-changing impact on patients because of the availability of the ACA funding justifies an increase in the territory's block grant. The devastating life and death outcomes that we face with the potential loss of this ACA funding without a resolution justifies an increase in the territory's Medicaid funding block grants. Last year, I had to make a difficult decision on whether we were going to refer a child, an infant of 6 months, to New Zealand, severely disabled cerebral palsy. We got the quote back from New Zealand that the child, ethically, they must accept, but prognosis, they do not think the child will survive beyond 12 months. And in that 12 months, they would have to care for the child because we can't care for the child on island. But the child will likely die anyway, and it would cost us $1 million, if not more. Our government only provided us $2 million in local match to do the off-island referral. We made a difficult decision to deny the referral of this child because we didn't have the local match. A few weeks later, the infant died. Currently, we have 2 patients in New Zealand. One is a middle-aged father who was sent for neurological surgery on his back. This week, we got word that the man is severely ill and requires triple bypass heart surgery at a cost of nearly $100,000. And I had to deny that because we don't have the local match. And just yesterday, I had to reverse my decision because the family is devastated. And we have to deal with that now on how we're going to make that payment when the invoice arrives in our office. We have one patient in New Zealand, a young man with his whole life ahead of him. And on-the-job injury, a pile of plywood fell on his back and broke his neck. And he had to be air ambulanced to New Zealand. And last week, New Zealand requested if he could stay 2 more months to do a sleep study to see how well he could survive if he returns home. Again, we had to deny the referral. But again, this week we reversed our decision because we have to deal with that. New Zealand won't discharge the patient. Ethically, they won't. Why are we sending our patients to New Zealand? Because we have a block grant, and we can't afford the local match. We cannot afford the Medicare cost in the U.S. For Congress to fail to increase the territory's annual Medicaid block grant and to provide a more fair AFMAP for the territories in light of the knowledge of the consequences in the loss of lives and potentially crippling physical and cognitive outcomes for our people because of insufficient medical funding is morally unconscionable.
Ms. King?
We need your help. Only Congress can solve these Medicaid challenges for the territories. Thank you, Mr. Chairman, and the
you.
committee for this opportunity. Thank you for holding this hearing.
Thank you very much for that, Ms. King. Ms. Avila from Puerto Rico.
Puerto Rico.
You're
Good morning.
recognized for 5 minutes.
Thank you. Good morning, Mr. Chairman, Member Gonzalez, and member of this committee. Thank you for the opportunity to testify today on Puerto Rico's impending Medicaid cliff. I am honored to be here on behalf of the government of Puerto Rico and to be at the witness table with friends and colleagues from the other territories. Puerto Rico's Medicaid program serves some of our nation's most vulnerable citizens. We serve approximately 425,000 children and 305,000 elderly and disabled. We provide care to 1.5 million individuals out of a population of 3.2 million U.S. citizens. Yet federal health care funding for Puerto Rico has been insufficient for generations. Puerto Rico's Medicaid system has been chronically underfunded due to a historical low federal medical assistance percentage known as FMAP, a correspondingly high local matching requirement, and the cap on federal funding. Currently, we are operating under increased Medicaid funding and a temporary 100% FMAP, which we received in the aftermath of Hurricane Maria, the worst natural disaster in our nation's history. However, this supplemental funding will expire on September 30, 2019. If not action is taken for fiscal year 2020, the FMAP will revert back to the statutorily mandated 55% FMAP up to the federal Medicaid funding cap of approximately $380 million. This level of federal funding is not sustainable as it will only cover 19% of the federal funding needed during fiscal year 2020 and will last approximately 3 months. Once this funding is exhausted, Puerto Rico will have not fully funded the deficit as it has in the past and paid for its medical services with 100% local funding. Given the island's current financial situation, local funding is not available. Unless Congress acts, we'll be faced with potentially catastrophic damage to our Medicaid program and our healthcare system. We will be forced to potentially remove any services that are not required under the Medicaid rules, such as pharmacy coverage, dental coverage. We have to end coverage for the current population who receive healthcare with local funds. We will face further delays in much-needed improvements to our hospitals, clinics, and other healthcare providers. We will continue to lose more of our medical providers because we will not be able to ensure reasonable reimbursement. We will face a mental health crisis as individuals and families continue to struggle to have their most basic needs met. Earlier this month, Governor Rosselló submitted Puerto Rico's official Medicaid ask to Congress, $15.1 billion in funding at an 83% FMAP for 5 years. This funding will provide Puerto Rico with certainty in the short term while we work together on a sustainable long-term funding mechanism. As part of the governor's request, we have identified critical sustainability measures needed to further stabilize and improve the healthcare system in Puerto Rico as a whole, which include keeping physicians within the system to avoid critical shortages, provide life-saving Hep C drugs, provide Medicare Part B premium coverage, and adjust the Puerto Rico poverty level to increase fairness in Medicaid eligibility. The Medicaid cliff that Puerto Rico is facing isn't an emergency that must be dealt with swiftly and smartly. I love my island. It is my home. And I am committed to working with Congress to create a Medicaid program that all of us can be proud of and that provides the necessary care to the 1.5 million US citizens who rely on it. Thank you for your attention and these urgent matters. I welcome any questions you may have. Thank you.
Thank you very much, Ms. Avila. We're going to go to questionings, members who have 5 minutes, but before I do that, I'd like to ask unanimous consent. I have a set of 6 questions. I can hear all of us here speaking to the fact that we all want to be part of the full Medicare program, state-like. And so I have these 6 questions that I'm going to ask you to take home, and if you could provide us your written response within 10 days, they would become a part of the record. And it's not just a matter of money. There are many requirements that all of us, our governments, have to set up before we could become eligible for the full program, like any state or like the District of Columbia. So if I may, I have for each one of you, all of the state directors, and Helen can share with Esther and work together on responses. Thank you for all of you for your valuable testimony. The chair will now recognize members for questions. And under Committee Rule 3D, each member will be recognized for 5 minutes. I'd like to recognize myself for, you want to
No.
Actually, I'm going to recognize the gentle lady from American Samoa first. She needs to fly out, catch a flight. This is Congresswoman Radiwagan. You have 5 minutes, please.
Talofa. Thank you, Vice Chairman Sablan and Ranking Member Gonzalez Colon for putting together this hearing on the Medicaid cliff currently facing the U.S. territories. The Medicaid funding is provided by the ACA is set to expire this calendar year, and the lack of a funding solution will be particularly harmful for American Samoa, as I know it will be for the other territories. I'd like to thank our witnesses for making the long trip to Washington to testify before the committee today. Welcome. Each of your firsthand experiences will provide Congress with an accurate assessment of the situation. ACA's first allotment of funds became available in July of 2011, long before I and many of us here were elected to Congress. Those funds were only accessible after the normal annual allotment was exhausted. The Medicaid and CHIP Payment and Access Commission, otherwise known as MACPAC, published a fact sheet for American Samoa, which has a historical table of total Medicaid spending from FY11 to FY17, taken from reported expenditures to the Centers for Medicare and Medicaid Services. The average total Medicaid expenditure in American Samoa, according to MACPAC's report, is $30 million for that period. Mr. Chairman, I ask for unanimous consent to enter into the record a March 2019 MACPAC report on Medicaid and CHIP in American Samoa, a May 2019 MACPAC issue brief on territory exhaustion of federal Medicaid funds, the April 2016 GAO report on Medicaid in the U.S. territories, and a letter to Governor Lolo Matalasi Molinga dated March 15th, 2019. I do have a couple of questions here for the director. The maximum FMAP is statutorily set at 83%. Now, if Congress is unable to align the territory FMAP formula to that of the states, is there a level that American Samoa, given an appropriate federal cap, would be able to sufficiently operate the Medicaid program?
The answer to that question would be yes. Our major Medicaid provider is the hospital, and the hospital has the best payment method under the state plan, which is a certified public expenditure. So we don't have a real issue with the local match or the FMAP with our local hospital. It really has to do with the new services and any future planned services that we want to do outside of the hospital, which is very much needed, and this includes the Department of Health. I cannot comment exactly on what the appropriate FMAP would be that we could give that would make it sustainable, but based on historical utilization of what we have used, it would be about 80%, minimum 80% for our FMAP. But we can definitely do more financial analysis, study our history of spending, and give you a more accurate FMAP.
Thank you. Thank you for your response. We know the FMAP and the federal caps need to be changed because they're not equitable for the territories. FMAP aside, what is the needed amount of federal funding to fully support American Samoa's Medicaid system?
Currently, we have submitted information that what we would like to request is a $30 million annual allotment for Medicaid. This is based on the historical spending out of the Medicaid spending that we have. I provided a chart of expenditures, historical expenditures based on the availability of the ACA that shows that we need for the hospital alone an additional $8 million for the $20 million federal share, and then we would need an additional $10 million for all new services for federal share. That would make it a $30 million federal share block grant increase for American Samoa.
Thank you, Director. I have more questions that I'll be submitting for the record. Mr. Chairman, I yield back.
Thank you. The gentlelady yields back. I'd like to recognize myself, but before doing so, I ask unanimous consent to enter into the record a letter from the Financial Oversight and Management Board for Puerto Rico, a letter from the Association of Asian Pacific Community Health Organizations, a letter from, oh my goodness, from national and community organizations, signed by, supported by many organizations, actually, at least 20, over 20. And also a letter from the Guam Regional Medical City that I've been asked to submit for the record.
Mr. Chairman.
Yes.
Mr. Chairman, sorry to interrupt. Can I do the same thing and introducing some?
When I recognize you, yeah. You
Okay,
can. Thank
perfect.
you. Thank you. And so now I recognize myself for questionings. Ms. Sablan, Hafaday, Helen, welcome. I want to compliment you on how you and your colleagues, including Ms. Muñoz, managed the Obamacare money. So American Samoa, Guam, and the U.S. Virgin Islands, they have hundreds of millions of dollars of Obamacare funding unspent, but you have been able to use up all your money. Is that correct?
Yes.
And you use certified public expenditures to make the local match and release the federal funds. Is that also right?
Yes, we work at the hospital to use the CPE for our local match.
And that is good because the Commonwealth government would have had to match the $109 million that we put into Obamacare with about $50 million of local funds. But the Commonwealth did not make that match, did it?
No, we did not have the money.
Interesting, actually, because all last year, the chairman of the Marianas Legislature Ways and Means Committee kept bragging about how he was responsible for the biggest budget ever in the Commonwealth history. yet he could not find matching funds for Obamacare Medicaid money. And so, again, as a result, I understand that you've had to stop making medical payments to private providers at this time, yes?
That's right.
And you also have had to stop paying for Medicaid patients to use the federally qualified Cacman Community Health Center. Is that correct?
Yes.
So could the Cacman Community Health Center also use CP system to make the local match?
No.
Okay, so, well, I know that our legislature is not paying its share for Medicaid. It's not your responsibility. You had to do the best you could with what you were given, or actually not given, I guess I would have to say, right?
Yes.
And working with the Federal Centers for Medicare and Medicaid Services, the Marianas Congressional Office was recently able to help you get another $8.2 million, but that has to be adjusted, and we could be now down at $4 million. But we also have another $36 million in the disaster supplemental appropriation, where it's my hope that you could see yourself through the end of the year. Would that help you? Help your program?
Yes, thank you, Congressman. That would be very much appreciated.
Okay, again, I want to thank you. I have a little bit more time now. Ms. Muña. Thank you also, Esther, for coming here, and thank you for helping managing this program, and of course, our only hospital. What I want to know, Ms. Muña, is how important Obamacare funding has been to the hospital. You said local funding was cut in 2010, about 40 million to 5 million, from 40 to 5 for your hospital. But then Obamacare began in 2011. Without Obamacare, would the hospital have stayed open?
I don't think so.
At the same time, you were losing local funding. You were also on the edge of losing CMS certification. Without Obamacare, would you have lost certification?
Absolutely.
Wow. And of course, if you lost certification, that would mean Medicare patients as well as Medicaid patients, as well as private insurance patients could not use the hospital. Is that correct?
That's correct.
So you testified that Obamacare money made it possible to see more patients and to expand services. You tripled your Medicaid staff, your medical staff added specialty services, including oncology, implemented a quality assurance unit. Is that right?
That's correct.
And Medicaid money helped.
Yes,
improve the
absolutely.
services. And as a result of these improvements, patient outcomes have improved for our Northern Marianas patients.
Yes, and they'll be able to take it, have it at home.
And readmission rates have improved.
Correct.
You said that hospital revenues also quadrupled during this time. It looks like the improvement in services that Medicaid made possible helped to make the hospital more financially viable. Is that true?
Yes, it is true.
So to summarize, the Obamacare that Congress provided you $109 million meant the hospital stayed open, helped you keep your certification, expand services, improve patient outcomes, and add to your bottom line.
Yes.
Okay, and my last 10 seconds. Ladies, please, the 6 questions you have, I would really like for you to respond in writing to the committee in 10 days. It's going to be part of the hearing record. It is critical that we answer that as completely and as correct as possible. Thank you. My time is up. At this time, I'd like to yield to my colleague, the ranking member, Ms. Gonzalez.
Thank you, Mr. Chairman. And before my time commences, I want to ask unanimous consent to put for the record memorandum of the Medicaid financing in Puerto Rico and the U.S. Virgin Islands made by the Kaiser Foundation. They were in a panel yesterday of healthcare that we did here with Puerto Rico administration, Moran Group, and many others in the private sector. So this will be one, and the second one will be another letter from the Puerto Rico Hospital Association to be introduced in the record.
Without objection, so ordered.
Thank you, Mr. Chairman. Now we'll begin with my line of questioning. And in the case of Puerto Rico, I got some slides regarding some of the data that it's important to know the difference. This is the Medicaid funding that has been approved for all the territories. When you see the difference of the spending in terms of how much is federal funding approved and how much is state funded or territories put in their money, you can see that most of our territories are actually doing the spending by using local funds to comply with the requirements of the programs. If the Congress is not acting, a lot of people are going to lose their insurance. A lot of people are going to lose their services, and that's the reason behind this hearing. The other information I want to show is how different it is, the spending for territories and for the states. In the case of Puerto Rico, as an example, you can have Mississippi and many other states receiving more than $7,000 per enrollee and less than $2,000 to our territory. And I know this is kind of the same thing with the rest of territories as well. That's the reason the FMAP, the formula for the matching funds, it needs to be changed. There are several options to this. We can have 100% federal cost share, like we did during the bipartisan bill last year, and Puerto Rico got $4.8 billion for 2 years, and they're going to be expiring in December. Or we can lift the cap of 55%. That would allow, in the case of Puerto Rico, with the per capita, up to 83% of federal funding. And I think this is the best way to do it, taking away, just allowing the territories to have the same formula of the states, and that's a bill that we actually file. And there, we're talking about how much money will be received in each state if we don't do something with that. In that case, I would like to ask, this is the difference between some states and Medicaid funding per enrollee. So the difference is we're not talking about a difference of just 20%. It's up to 80 and 70% of difference, the funding that the states are receiving. So in the case of Puerto Rico, we're losing providers, we're losing doctors. Our professionals in the healthcare system are receiving less than a half of whatever other professional is receiving in the mainland, and that's the reason we're losing a doctor per day during the last years. During the last 10 years, we've been losing a lot of our professionals, even lacking of specialized physicians. So, Ms. Avila, I would like to begin with you, and I would love to have an answer directly on yes or no, or the numbers. How many people in Puerto Rico will lose their health care coverage if we do not address the impeding Medicaid cliff, and how many people will see their benefits or coverage service be reduced if Congress is not acting on September of this year?
We are expecting just we have find out according to the written statements that we already have received.
I just need a number.
Well, approximately 600,000 life, and that will be if we can keep the program viable for Puerto Rico.
Okay, 600,000 people may lose their insurance if we do not act on September of this year.
Immediately,
Okay.
that's right.
During the last Congress, I just said that we received $4.8 billion that were approved and President signed after the hurricane season. Out of this funding, $1.2 billion were made available through HHS. If Puerto Rico certified that they have reliable data to the Transformed Medical Statistics Information System and establish a Medicaid fraud control unit. Question will be, has Puerto Rico been able to access the entire allocation of $4.8 billion, including the additional 1.2?
Yes, the answer is yes.
Did HHS certify that Puerto Rico was reliable reporting data and establish a Medicaid fraud control unit?
Yes, that's correct.
How does the unequal treatment under Medicaid program and the fact that we're losing a lot of our people every year, how the government of Puerto Rico have the ability to budget for modernize and reform our healthcare system if we don't receive the money?
We are not allowed to forecast any funding that we don't have any assurance. It has to be certified. This is because the fiscal board requires that.
So the oversight board required to the island to include all future plans regarding healthcare, and that means if we don't receive the money, the state, in this case Puerto Rico, needs to put upfront the money from the state to do the job that the federal government is supposed to do in the state.
Yes, that's correct.
Thank you. I will wait for a second round of questions. Thank you, Mr. Chairman.
I like the ranking member's suggestion, but thank you. This time, I'd like to recognize the gentlelady from the United States Virgin Islands, Ms. Plaskett, for 5 minutes.
Thank you, Mr. Chairman, and thank you to all of the witnesses who are here. I did not see Mr. Smith with you, sitting behind you. I guess he's there to provide support and any additional information. Thank you as well for being with us. I wanted to just get straight to the questions because I know in your written testimony you give a lot more statistics and a lot more specific examples of how this has affected us. We've seen on the chart that was demonstrated by my good friend and my colleague about how the difference between what we've provided locally as well as what the federal government was provided. But one of the things that I need to highlight, and I think would be important for you to highlight, specific to the Virgin Islands, which may be different from other places, I'm not sure, that you stated that there were approximately how many people that would need to come off of the books or the support that we're receiving now if this funding ends, meaning how many people are presently that we've been able to include that no longer will be able to receive those services?
We would have to reduce upward of 15,000 individuals of the 27,000 approximately members of the Medicaid program.
Great. But I think another number that was not brought out that I would love for you to, if you have that number, is how many individuals would we like to bring on the rolls that we believe qualify for Medicaid, but we have not given those services to?
An additional 15 to 20,000 individuals who would be eligible for the Medicaid program.
So there are individuals that are presently in the Virgin Islands, maybe in other territories as well, who are just not receiving any health insurance. We have a large population that have no health insurance that would qualify, except for the fact that there is this arbitrary cap that has been put on the amount of money that Congress gives to us. And the Virgin Islands, rather than going out and borrowing money, finding other ways, we have done the fiscally prudent and responsible thing and said we just can't service those individuals. Is that correct?
Exactly. That is correct.
And how are some of the other ways that this is impacting us? If you can talk about the hospitals in the Virgin Islands. Presently, we do not receive DISH as other places do for the disproportionate share for hospitals. That is an additional bump up that's given in rural areas. Although the Virgin Islands qualifies for it and meets the qualifications, Congress and CMS have said we would not receive that. What are some of the other ways that our hospital healthcare services are impacted because and the trickle-down effect of not receiving this funding?
Well, our hospitals on an everyday basis is struggling even now. Since 2017, they have been experiencing extreme infrastructure issues. The hospital is unable, because of the limited monies that we're able to give them, to be able to bring all of the specialties and all of the specialized equipment. That is one of the reasons that the hospital has frequently called us over the last 2 years to airlift many of the individuals who go there who have real catastrophic illnesses and needing specialized procedures. So the hospital, in effect, has to turn away several individuals who have these extreme circumstances and illnesses, and we have to airlift them to the United States for treatment.
Thank you. You also, I know that our governor has declared an emergency with mental health issues and others. Can you talk about that very briefly?
Yes, our behavioral health situation is really burdened right now. Again, the need for more psychiatrists, the need for more of our individuals to have long-term care, behavioral health services. This has been hampered because of just the inequities of our hospitals and of our Medicaid program as a whole. It is very, very important for us to also have a skilled nursing facility in both districts of the U.S. Virgin Islands. We do not have skilled nursing program within the territory. Our hospitals are really burdened to provide behavioral health services as well as our community clinics.
Thank you. And finally, could you state the things that the Virgin Islands has done, things that we put in place to provide the compliance and the accountability that Congress has asked for Medicaid? I know that there are quite a number of systems that we put in place.
Certainly, we implemented the first ever territory Medicaid Management Information System for claims. The CMS also certified MAGI compliant, our online Medicaid eligibility system. We too implemented a Medicaid fraud control unit in 2018. We also implemented the TMSIS, the Transform Medicaid Statistical Information System. We also will be completing all of our cost report audit reconciliations of our 2 hospitals. We recently completed the Medicaid Program Integrity Review, and we have a host of other programs that we have been going through for the last few years, and especially with the ACA dollars, we've been able to do all of these things that I just mentioned prior.
Thank you so much for all the work that you're doing, and thank you, Mr. Chairman, for allowing us the opportunity to highlight those for our colleagues here in Congress.
Yeah, thank you. We're going to have a second round of questioning, and I'm going to start with myself, please. Ms. Reimer Brown, you just, including in your written testimony, but you just listed a series of items that you implemented in your program, establishing the relationship between the extra Medicaid money the Virgin Islands received in last year's disaster appropriations and the improvements you made in administering the program. Fraud unit, you began reporting data to CMS through the Medicaid Management Information System. But you were able to do that because of the incentive funding included in the disaster bill. Is that correct?
That is totally correct. Without that, we would have been unable.
That was my next question. I think you're reading my script here, right? And without that incentive funding, you would have been able to. Would you have been able to add those state-like features to the Virgin Islands Medicaid programs?
Could you repeat that, please?
Without that incentive funding, would you have been able to do what you did?
No way, we
Okay.
could not have.
So it seems to me there's a model there for how we can add other state-like features to the territorial Medicaid programs. That if we provide incentive funding, if we give you the resources you need to build capacity, then you're willing to do it. Is that right?
We certainly are.
So I mean, congratulate the Virgin Islands on the work you're doing, and I do think what is happening in your islands could be a model again for how we make Medicaid more state-like in the other insular areas. To thank you for showing us what can be done. So let me ask the other directors very quickly, if you had upfront money to make your programs more like state-like, in terms of the services you offer and in terms of how you manage your system, would you make those changes become more like a state, Ms. Sablan?
I think so.
Okay, Ms. Archangel?
Definitely.
Ms. Young, Director Young, could your program be run like a state if you had state-like funding? Thank you.
Believe so.
Thank you. And how long do you think that would take? Could you do it over a period of 10 years? Would that be reasonable, Ms. Sablan?
Probably.
Ms. Archangel?
I think so, yes.
10 years. I didn't hear your question, your answer.
Yes.
Okay. Wow. And Ms. Reimer Brown?
Yes.
And of course,
Yes, I think that's reasonable.
Ms. Avila, I'm not ignoring you. It's just that Puerto Rico's program is so huge. But would you also be able to do these things, and some of which you are already starting to do?
Yes, the answer is yes. Thank you.
Okay. Look, the fact is that the federal government isn't saving money by not treating the territories equally in Medicaid. It has been a big factor in many territorial citizens moving to a state. So for example, many Puerto Ricans have abandoned territory for a state that is more than 3/5 of all people of Puerto Rican heritage live in the states. Further, Medicaid programs in the states spend multiples per beneficiary of what territories spend. In the case of Puerto Rico, 3 times as much. They're not treating us the same. They're not treating anybody differently. It's just an issue that. Yeah. So they're not saving any money, right, Ms. Avila? By not giving you the money, the federal government is not saving money because your citizens move to Florida and.
I will say that it's more costly for the states to have our residents here.
And also costly to us because we're leaving we're having our people leave home. And again, I cannot overemphasize the importance of your written response as concise and as complete to the 6 items I gave you. Those are going to, again, go into the record. It will be shared with the Committee of Jurisdiction, Energy, and Commerce, and it is a plan that would allow its territory to work through a program, get financial incentive to do those things that require us, that will get us, hopefully, to a full state-like Medicare program, not just in terms of money, but in terms of services to our citizens. My time is up. This time I yield to the ranking member, Ms. Gonzalez Colon.
Thank you, Mr. Chairman. And I will take the same question you were making yes, it is on. You were saying about American taxpayers' money will be more effective if we address this issue now. Because in the case of Puerto Rico, at least more than 1 million Puerto Ricans who just moved to Florida. In our case, we just take a ticket and we move through the state and we receive the full benefits. So it will take more money to the United States to address this issue in the long term. If we fix it now, we may save a lot of federal funds. So in that sense, I would like to ask Ms. Avila, Puerto Rico at this time just offers 10 programs of the 17 Medicaid programs. Is that correct?
Pardon, could you repeat the question? I'm
Yeah,
sorry.
the federal rules for Medicaid in Puerto Rico, for all the state benefits, are generally applied to the island. But because we don't have enough funds to match the federal share, we are required to limit a lot of those benefits. So we are just offering 10 of 17 programs in the island. Is that correct? Yes or no?
I would say that I don't recall 10 or 17. I can mention.
Just tell
at
me
least
the
ones.
programs that do not apply to the island yet.
Well, right now we don't cover Hep C patients within the program, and even we have a cure right now for that condition.
What
we
other
are not
program?
able. Non-emergency transportation, we haven't been able to cover.
What other program?
Long-term care, we lost a lot of people.
What other program?
Those are the main ones that I can highlight right now.
Okay. In terms of you mentioned in your written statement that due to the Puerto Rico's unequal treatment and the historical low funding, we've been forced to limit Medicaid eligibility to income levels well below the federal poverty level used by the states. Puerto Rico have 47% of poverty level.
That's correct.
So what benefits are the one you're limiting?
Well, the main ones will be pharmacy benefits and dental coverage benefits. Drugs are medular for a healthcare system, and we will not have funds to be able to sustain the drug program within the Medicaid program in Puerto Rico.
So in your experience in having identified various of the programs, including drugs, how many Medicaid-eligible individuals in the mainland are not currently covered in Puerto Rico because of the disproportionate low-level federal funding?
It will be, we are estimating like more than 500,000 U.S. citizens has not had the right now to get into the
more than
program.
500,000 American citizens living in Puerto Rico, they're not covered by Medicaid full programs as they were in the States, just because of the lack of funding of the treatment of the state of Puerto Rico. And I know the same case for the rest of the territories as well. Because if you don't have the funds, you need to be cutting some of the benefits in order to have more people, or trying to at least address the most urgent needs of the island. During the year 2006 to 2016, the numbers of physicians, surgeons, and providers of the island dropped from 14,000 to 9,000.
That's
Is this trend exacerbated by the hurricanes in 2017?
That's correct. It has been.
Do we have a new number of how many physicians and surgeons do we have in the island at this time?
Well, we are just validating the numbers,
Okay.
but we have received preliminary information towards 3,000 or more physicians have left the island since the hurricane.
So we can say that between 6,000, 7,000 physicians and doctors are still on the island.
That's right.
And that trend will continue if they're paid less than the rest of the physicians that providing the same service that will receive in the States. I got, my time is running, but I do want to have some questions for the record, and so you can answer later on. And that will be specifically for all of the territories represented here. I know you do a lot with less resources. And one of those will be how much did Medicare program benefits actually cost in the States? And in the case of Puerto Rico, there's no real Medicaid financial cliff for Puerto Rico. This is the Promesa board saying a few weeks ago. You say now in the letter that it was submitted for the record, they're endorsing receiving the Medicaid funds for Puerto Rico, and I think that's finally common sense. But there's some, and this is for American Samoa, and I will then end here. During this fiscal year, there was a news balance of $153 million in Affordable Care Act funds in American Samoa. You explained the reasons for this balance in your testimony, but my question will be, and you can answer it later on, do we need to do something for the territories so they can spend the money? Is there any other requirement the federal government, CMS, HHS is given to the territories so you can access those funds? What's the reason behind it? And with that, I'll yield back the balance.
Thank you. The gentle lady's time has expired. But I also agree for American Samoa, it's an anomaly. There are not too many private providers. I found that out after our last time that you were on the witness stand, Ms. Young also. Ms. Plaskett has 5 minutes, please.
Thank you. I won't use the 5 minutes. I'm needed in another meeting, but I just wanted to follow up with a couple of short questions, particularly, of course, for the good woman from the Virgin Islands, Ms. Reimer Brown. You talked about the disaster-related circumstances in which we've been given $100,000, that if we move back to the 55% match that had been previously, that cap would bring us to about 18.7 million, correct? And what is the
Correct.
amount? And what is the amount of money if we were given the state-like treatment that it would be at? Do you know what that number would be?
I am not sure. However, we are requesting, as I said, for the 100%, we would be requesting $251 million for 2 years, and then we would continue at the 83% federal level, and those would be for the next 3 years. But I'm not sure exactly that number.
What the percent of the 83 would be?
Yeah,
But we know that for 55%, it would be 18.7 million, right?
Yes.
And that's woefully inadequate. What would be the delta that you would need from the 18.7 million to satisfy the needs of all the individuals that would, if given state-like treatment, be eligible for it? We're not sure at this time?
We're not sure at this time.
Okay, but if you could get that number to me, that
Yes,
would be
we
really
certainly will.
helpful for the record. One of the other things that I wanted to talk about, we talked a little bit about the physicians, and can you state specifically what specialty services we are not providing for individuals right now?
Yes, there are several cancer-related situations that we need to airlift. Our major cancer center was tremendously damaged on the island of St. Thomas. We used to fly individuals from the island of St. Croix over to St. Thomas, but now that center has been down for the last 2 years. The orthopedic specialists, the trauma specialists, when we have major accidents and situations, workplace accidents, we have to airlift our members off island to receive the treatment on the mainland.
And how does this impact recruiting physicians to the Virgin Islands in terms of if there is a belief that we will be reduced in our Medicaid treatment moving forward, how will that impact the ability to not just have specialty doctors, but to have regular physicians, general practitioners, pediatricians, et cetera, to treat this population?
It would greatly reduce it. Before our ACA treatment and getting the additional monies, we were perhaps maybe at about 200 to 300 providers. We have over 700 now because individuals were attracted that we had the additional monies to provide services for our members. But if we were to be reduced once again, the ability to attract those specializations would be it would be very hard for the territory to do that.
Thank you very much. I saw you had a note. Was there anything you wanted to add?
Yes, he has, what is it, 87.2?
Mr. Smith, she can't read your handwriting. You're not only the director of Medicaid, you must be a doctor as well.
Okay. At the 55% federal, we would require 87.2? Is that correct? And at the 83%, 52.6.
Okay, thank you very much. And I yield back the balance of my time.
Thank you. And I now recognize the gentleman from Nevada, Mr. Horsford, for 5 minutes.
Thank you, Mr. Chairman, for organizing today's hearing on the funding of Medicaid in the U.S. territories. I appreciate the opportunity to discuss the shortfalls of Medicaid funding in our territories and shed light on this very important issue. To start, I want to make it clear that it is my priority as a member of this committee as well as the Ways and Means Committee to ensure all Americans, including those living in U.S. territories, have access to affordable and quality health care. Sadly, as is often the case with the federal government's treatment of American Samoa, the Northern Mariana Islands, Guam, Puerto Rico, and the U.S. Virgin Islands, U.S. citizens and nationals living in the insular areas do not receive the same services and benefits afforded to the rest of the American people. That's a very sad fact that we need to address. American citizens living in our territories are too often overlooked, mistreated, and forgotten, and the government services many of them depend on are treated similarly. Territories commonly experience higher rates of poverty than states, and in many cases, our territories depend on Medicaid even more than our states. For example, in American Samoa, because private health insurers refuse to provide the island health care coverage, Medicaid is their only option. Sadly, due to significant shortfalls in federal Medicaid funding, territories face serious challenges finding the funding needed to support Medicaid coverage for all those who depend on it. These challenges have increased in recent years as debt crises, decreased tourism, and natural disasters, including hurricanes and typhoons, have added to their burdens and heightened economic distress. As a result, all territories are forced to cut Medicaid programs, heighten eligibility requirements, and limit coverage options. We cannot continue to stand by while people in need lose their health care coverage. Our territories face a significant crisis, and they need this Congress to find a Medicaid funding solution that can address the serious funding setbacks they face. More than 1.3 million people in U.S. territories rely on Medicaid, which provides health coverage to children, pregnant women, parents, seniors, and individuals with disabilities. Without a Medicaid funding fix, thousands of individuals in need risk losing health care coverage and benefits under Medicaid. I want to thank each one of you for your testimony today. I hope your insight can help the members of this Congress better understand the challenges our territories face and solutions that are needed. Ms. Sablan, I want to share my sympathy with you and express my regret that you and your colleagues have been forced to make such tough decisions regarding cuts to Medicaid. Can you talk through what services the Commonwealth would be forced to cut if we do not address the Medicaid cliff? Will women not be able to get a mammogram? Will children not be able to have an annual physical? Will seniors lose access to nursing facilities? What options are left for these individuals if they lose their Medicaid coverage?
We will have to cut those not optional services and some of the mandatory services, because by first quarter of the fiscal year, we exhaust our 1108 funding.
And explain what you mean by cut optional services. When I was in the Nevada State Senate and we had a Republican governor who wanted to cut Medicaid across the board, it meant cutting diapers from seniors in nursing homes. And we rejected that. So what does it mean to you?
Optional services includes prescription drugs, dental services, and other care services that is critical for our patients.
And what will happen to those individuals without that support?
Well, if they don't get their medications, then eventually they will end up at the hospital, and that will cost us more money in our inpatient services, as well as dental services. If they're not treated, then they're going to end up in emergency room services, and that costs us more money.
Right. And again, is it the case that there are no other options available to them?
There's no other options because they don't afford to get health insurance. The income that they get is pretty much to put food on their table.
Thank you very much. This is a very important issue, one that affects all the U.S. territories, and I commend the chairman and the members of this committee. We have to address this issue, and it cannot continue to persist. Thank you. I yield back.
Thank you to the gentleman. I recognize Mr. Cox from California. Do you have no questions? All right, there's another Californian on the table here, Mr. Lowenthal.
You can yield.
Thank you, Mr. Chair, and I thank you for recognizing the great state of California also. If Congress, I have two questions. One is about the future, and one is a little bit about how we got here. First question is, if Congress does take the steps we've discussed today to treat the territories equitably, such as providing uncapped Medicaid funding, calculating fund matching in the same way it does for the states, really begins to treat the territories as part of the United States in an equitable and fair way. Are there any mandatory Medicaid benefit requirements the territories still wouldn't be able to meet due to territory-specific limitations? Are there still other things that need to be addressed? Maybe anybody from the committee, are there any unique characteristics of any of the territories that will prevent you from being able to provide mandatory, the mandatory Medicaid benefits? Are there still going to, we have to get rid of the cap, we're hearing that. You have to have the match in an equitable way that doesn't penalize. But what else should we be, is there anything else we should be looking at also to make sure that the uniqueness of the territories does not preclude them from receiving certain benefits? Anybody, does it, because we're really trying to figure out where do we go from here.
Yes.
This is Angie Avila from Puerto Rico. Well, besides what is medular for the healthcare system within a Medicaid program, just to be able to have keep the exodus of the doctors and healthcare providers, it is a great challenge for the island and for the other territories as well. So we need to find a way to, with these funds and with the structure that we already have developed, just to start stabilizing the program and see what other needs we will need to confront right now. But it's so urgent just to keep the doctors in the island. It's so urgent to avoid the hospitals to collapse that I will say probably we will need to have more support in terms of long-term care to develop the structure to support that population and that area, but will be according to the guidelines of the CMS or HHS Federal Healthcare Program that we will need to identify what else we can do better just to have a more continued and sustainable program in the island.
Thank you. Anybody else want to add something that might be?
Yes, I just want to echo for the long-term care that this will be a very, very important area for the U.S. Virgin Islands. We have an aging population, and from CMS, we definitely would need additional technical assistance to not only obtain skilled nursing facility certification, but to maintain the skilled nursing facility certification. So that technical assistance would be greatly, greatly needed.
The other question I have is a little bit, that's looking forward, what you need. How did we get here? You know, and I don't know if anybody can answer it. I'm just sitting here wondering, in the negotiations, does anybody, maybe the Gregorio knows better, in the passage of the ACA, there were benefits. There was the Medicaid expansion, and in some sense, it did provide for certain kinds of services for the territories. Yet, looking back, it was a terrible hindrance also. It put limits on the territories that it did not put on the rest of the country.
How
did that happen?
Would the gentleman yield?
Yes, I will yield.
When we had passed the Affordable Care Act,
Yes.
And the PPA also, under the budget reconciliation process, we had to address the Senate bill. At that time, in all truthfulness, we couldn't go into conference because when we come out, there would not be enough votes to pass the bill.
Okay.
So we used the budget reconciliation process, and of course, we had to go with the Senate version, which the Senate addresses states, not territories, and so we worked with the White House, and we got increased money,
right?
In addition to the regular block grants, but those monies were used as block grants itself. Now, with additional, if we're going to get into the full program, there has to be also made improvements to not just the procedures and the process of the program, but also the care, the standard of care for patients. So the improvements that they would implement to satisfy Medicaid would not just benefit Medicaid patients, they would also benefit the entire patient population in each of the territories or combined, like they do in the states. So they would provide services that are not at the present time available to the territories, but are available in the states. And we could do this over a period of 10 years. There would be money to help them, incentivize them to meet those standards, and at the same time allow also, maybe one territory could get this done in 5 years, and the other one may take 6 years. So allow them to work with the Secretary of HHS, and when they meet those, submit plans, when the HHS Secretary approve a plan, and then that territory would get into a full Medicare program, right. Medicaid program like they do in the States. And the rest would take the additional time they would need. So it would take time, it would take incentivizing them. Of course, they would need financial assistance. But yes, it can be done, it's possible. And And that's also for me personally, that's my hope and that we would get into the full program. Did I answer the gentleman's?
Yes.
Thank you, and your time is up, so I must, thank you.
And I use my time very wisely.
No question, you always do, Mr. Lowenthal. Mr. Tonko from New York, he's recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to our witnesses as well for being here today. Certainly, I believe in the richest country on earth, healthcare should be a guaranteed right for all, full stop. And not just for residents of the 50 states, but for all who call themselves Americans. Unfortunately, healthcare in America has always been segregated between haves and the have-nots, and the status of Medicaid in the insular areas is no exception. Like many aspects of federal law, the way that the Medicaid program views the insular area is as second-class citizens, providing fewer resources and less predictability to care for some of our most vulnerable. The territories are generally poorer than the 50 states, but are subjected to Medicaid funding caps and restrictions that have made it significantly challenging for them to provide services to individuals living below the federal poverty level. Despite temporary increases in federal Medicaid funds, the Puerto Rico and U.S. Virgin Islands healthcare systems are fragile, especially in the wake of Hurricanes Irma and Maria. Following these two disasters, residents have struggled with substantial health needs. It is imperative, I believe, that Congress properly address the Medicaid financing issues. Expiration of funding could result in even more significant shortfalls and could further restrict programs' eligibilities and cut benefits and suspend programs. This could be devastating for territory budgets, coverage, and healthcare systems more broadly. So my question to Ms. Sablan or Ms. Young and Ms. Young, both American Samoa and Commonwealth of the Northern Mariana Islands rely on a single hospital to provide most of the care to Medicaid beneficiaries. What are some of the challenges that arise with this model, and would having uncapped Medicaid federal funding and a higher federal match help the territories draw in additional providers outside the hospital system? Ms. Sablan?
Can you repeat your question again? Sorry.
Sure. With your reliance on a single hospital for most of the care for Medicaid eligible, what are some of the challenges that arise with this model, and would having uncapped Medicaid federal funding and a higher federal match help the territories draw in additional providers outside those in that hospital system?
Okay, so we will have to send our patients off island, either to Guam, Hawaii, or the U.S. mainland. And it really is costing us a lot of money to send our patients with the cap, the limited cap that we get, and then requiring our local match.
So if we undo the cap and provide for higher federal match, what is the impact, do you think?
Well, that would really help us. We will be able to provide more services.
And Ms. Young, do you have any response?
Yes. To answer the first prong of your question, we provide basic services at our one hospital, and basically in our state plan, medically necessary care that is not available in our hospital must be sent off island, and currently we send our patients to New Zealand because it is the closest country to us. It's closer than Hawaii. Mm-hmm. So everything from orthopedics to cardiology to urology, acute, serious pediatrics go to New Zealand. If we were given, if the cap were lifted and we received a better FMAP, that would truly transform our healthcare system. And what is amazing about this situation, if you look at the territories, it doesn't take much in the overall scheme of the federal budget to just give us a little more in our block grants so that we can fully provide the services to our people and care for them. So if that cap was lifted and we got a better FMAP, absolutely we would be able to provide, to recruit more providers in our island, because that's part of our problem. We don't have enough certified doctors for CMS, compliance issues and reimbursement requirements. I think there are 3 doctors with MD degrees from the US that allows us to claim for Medicare, but if we had more funding to recruit doctors from the US with MD degrees, we would be able to, do more of the, those types of claiming.
Thank you. Mr. Chair, I yield back.
Thank you, Mr. Tokat. Now I recognize Ms. Gonzalez Colon again for 5 minutes.
Thank you, Mr. Chairman. I think, and I want to thank Mr. Tonko, Hosboro, and Soto, and all the members that are here, taking into account the situation in the territories. I think it's important for Congress to do something. And I'm willing, Representative Puerto Rico, to work across the aisle to reach a long-term solution for territories. And I think we can do that in the Energy and Commerce Committee, that actually they went to the island during the last Congress, both today's chairman as a ranking member at a time. And I think there is a common sense opportunity to reach an agreement. And there's 2 bills that have been filed. One of Ms. Blasket that has been sponsored by all the members of the territories in a bipartisan way, HR 2306. And the other one is HR 1354, and I commend the members that can co-sponsor those bills that will find a solution, a permanent solution, even taking the cap 55% off, or increasing the funding for Medicaid in Puerto Rico and the rest of the territories as well. And I want to commend Mr. Soto for always being original co-sponsor of all those bills. And I think this is something that we can achieve during this Congress, knowing that most of the territories suffered different disasters, including typhoons and hurricanes during the last 2 years. Mr. Archangel, you were willing to answer the last question, and the time was up. Can you finish?
Thank you, Senator. Sorry, thank you,
Not yet.
Congress.
When we become a state, I will be a senator, but now
Sorry.
I'll become in the House.
Thank you, Congressman.
Go ahead.
I'm used to speaking to Guam senators, I'm sorry. Yeah, to answer the questions of Congressman from New York, increasing the cap or increasing the FMAP and removing the cap will definitely help all the territories. One, for Guam, our experience is because of lack of funding, local funding, we're unable to match the federal. So what happens then is because we have delayed payments to our providers, they don't accept our patients, even for off-island providers. What happens? Our patients become more sick, their condition becomes more complicated. So the cost of healthcare increases while we're waiting for a local match to draw down the federal funding. Our patients are staying in the hospital. Though we have 2 hospitals, we don't have a tertiary center, really, that's complete with specialists who can handle these people, even for nurses. Tertiary centers requires all the professionals in order for them to completely heal the patient. But these patients are waiting months in order to go off-island because the providers off-island does not want to accept our patients because of the late payments.
Thank you, Mr.
That's
Quillo.
one of that. And one more thing with regards to the other congressman.
Don't have use of my time.
Oh, okay, I'm sorry. I just want to emphasize.
It's okay, but I will let you. Okay, perfect. Go ahead.
Sorry, I just want to emphasize that the territories does not receive any dish money, and that will help our hospitals.
The dish money, for the knowledge of the members, is this proportional share hospital segment, and that means that the low-income patients are being attended by many of the hospitals without receiving their fair share in order to make that happen. Same thing happened with the low-income subsidy and the HIT, the health insurance tax. Our hospitals are paying a tax included in the Obamacare, but we can't benefit for that, the tax incentive that the law provided for those hospitals. In the case of Puerto Rico, we're paying more than $200 million a year in the health insurance tax without getting the benefit. And I know it will be the same for all the hospitals because we don't have the exchange. So there are several parts of healthcare problems. Medicaid is one of them. Medicare is another problem as well. And I began the question during my last term to a lady from American Samoa, and I know we knew each other. I think, how long you been in the post? Ms. Young? 6 years. So what is the reason that American Samoa have not used or spent the money that was allocated to the island?
Up until 2017, we only had one Medicaid provider, which is the hospital. And the hospital doesn't provide all of the mandatory services under the Medicaid program. In trying to reform our Medicaid state plan to add new providers to try and help us draw the federal money, the barrier for that was the local match. So for the first time, our government was, when our administration came in, there was a lot of old debt that their priorities was to focus on. So we weren't able to get local match for new services until 2017. Our hospital doesn't require a local match, but all new services outside of the hospital requires a local match.
I will yield, and I would love to have recommendations from the territories that have not spent the Medicaid funds. Given any problem you're facing, you've been 6 years there, so there should be some recommendations in order to actually draw that money. With that, I'll yield back.
The gentle lady's time is expired. Thank you. And I'll recognize the gentleman from Florida, Mr. Soto.
Thank you, Chairman Sablan. That does sound nice. Not as good as Grijalva, but still.
I always suspected you, Darren, but not.
Chairman, I'm still with you. I'm Team Grijalva, but I love Sablan. You'll get your time too. There's been a long-running injustice in this country, and I think we all understand that, with our territories with regard to health care, taxes, benefits, even the right to vote. And we continue to be in this committee to right those wrongs, to fix those injustices. In Puerto Rico, under the current Medicaid system, we've seen over 6,000 doctors leave the island, many of them for our great state of Florida. Hospitals in disrepair, debt added to try to prop up a Medicaid program, all because Puerto Rico is not treated equally for purposes of Medicaid. And I know there's a similar story in each of our territories. And that's why we're here today. I have the honor of serving on the Energy and Commerce Committee. That has been, the name's been evoked about 100 times today, so you're looking at someone who will be working in both committees on this issue specifically. But it gets worse than that with Hurricane Maria or Typhoon Utu. You know, our territories have been decimated by some of these storms, and it's led to tragic deaths that are in part because of the lack of money in the healthcare system to be able to provide people with health care after these emergencies, including in Puerto Rico and the Virgin Islands and in the Northern Mariana Islands, along with other areas. So if you remember nothing else, it's time to end this injustice, and that's why we appreciate all of you coming from so far away, from so many different corners of the United States to be here today and to make sure that Americans have healthcare equality throughout the territories. I want to thank my fellow hermana Boricua, Representative Gonzalez Colon, as well as Representative Plaskett and Sablan and San Nicolas and Radawagan and others, because HR 2306 and 2304 are great ideas and starting points of where we need to be in energy and commerce with regard to these bills as well as here. We'd like to remove the cap altogether, and we'd like territories to be treated as states and get the same type of treatment that they would get otherwise. And I think that's where we want to go with either these bills or with sort of a combination of them. Another bill that we'll be working on is to give access to the Affordable Care Act exchanges, which right now the territories don't have access to. In my family's native island of Puerto Rico, only 30% of people are on employer-based insurance, which is mind-blowing compared to the states. And so we need to boost that up. I noticed, and this is where I'm going to get to my question for each of you, because you're not fully funded with Medicaid, some of you aren't providing all the services yet, although Guam, who's from Guam? Guam is doing all those services already, so you get the gold star for today. Very impressed since you're not getting the full funding to do that. But for each of you, going down the list, it'd be great to hear if we provided you the full FMAP funding that you would get as a state, whether you believe you could provide over the course of a certain number of years all these services. And we'll start with Ms. Avila, and we'll go down the list. If you got the full Medicaid treatment that a state would, the full funding, would you be able to provide all the services under a mandatory Medicaid benefit, and what kind of time period would you need?
Well, we are talking about that we will start immediately just adjusting the reimbursement rates to our medical providers. And I will say that in a time frame of no more than 3 years, we will be able to stabilize the program as it needs right now. Because the uncertainty that we have
I understand.
is one of the most
My time's limited,
impediment.
so just want to get other people. Ms. King. Excuse me, Ms. Young, sorry, Ms. King Young.
Thank you. Yes, we would be able to do a lot more if we were treated equitably like the states in receiving uncapped funding as well as an improvement in the FMAP. We would.
Ms.
Yeah.
Reimer Brown?
Yes, we would definitely be able to do more, and one of the areas would be to increase, well, even develop our skilled nursing facilities and not have a cap when we do have the skilled nursing facilities.
We already covered Guam, so Ms. Sablan?
We'll definitely provide all the services that's mandated. Right now, there's some that we're not covering because
Of course, because you're not getting full funding, I understand that. And Ms. Muna?
We're already providing some of the services, and we'll be definitely expanding and providing more services for the community at home.
Thanks, and I yield back.
I thank the gentleman. I now recognize the chairman of the committee, Mr. Grijalva.
Thank you very much, Chairman Sablan. And like I said earlier, I appreciate you putting this meeting together, this hearing. It's impactful, and to shine a brighter light on this inequity that every one of you has spoken to, both in your oral and written testimony. And it's an equal treatment issue to me, very fundamentally and very simplistically. And the way to deal with that unequal treatment is to create resource equity on par with what communities here in the United States on the mainland receive, period. That's the goal. And I look forward to the various legislation and under Mr. Sablan and the representatives from all the territories and Puerto Rico. I think that from that would come a significant piece of legislation that we can look at, promote, and certainly I would be talking with Chairman Pallone about expediting a good piece of legislation to start to move that. Having said all that, I really want to ask one question to all of you. And it was a question that, just one question, and thank you all for making the effort and coming from such a long way to be here. The one question is, if you had to choose between a larger federal match around 85%, okay? For example, 85%, or more money, or just more resources and more money, but the same 55-45 match that is present. Which would you prefer and why? You know, I think that's the question. Why don't we just add more money to what exists versus fundamentally making the formula equitable, but the reimbursement formula equitable. But that's the one question for all of you, and we can begin with Ms. Muñoz. Then we can just go down the panel, if you don't mind. Thank you, Mr. Chairman.
If we were going to choose, we would have to choose the more money over the FMAP, over the FMAP. And the reason is, even if you increase the FMAP, for us personally in the hospital, we use the certified public expenditure. If the funds are not available, you won't be able to, even if you increase the FMAP, you basically just be faster for you to expend the money rather than having actual cash available to pay for services that you're going to provide at home.
Okay, thank you.
I go with the removal of the cap instead of the FMAP. And the reason why is we're spending more. We're spending over 72 million.
The same way for Guam. We spent 110.8 million last year. So if you're just going to increase the FMAP, our current cap right now is 17.97 million. That's not enough to pay for those services. So we prefer to increase the funding.
Very hard. We would need more money, so definitely we want the cap off, but the FMAP is needing to be off as well, because more money and still have the 55% FMAP would make no sense. We can't make it. We can't go after it as seen in the ACA dollars.
I think for American Samoa, this is an interesting question. I think in an ideal situation, both of these options need to be addressed simultaneously,
Yes.
complementary. But if we were given an option, then we would have to go for the more money lifting of the cap. But what we would have to do as a territory then is we would have to permanently omit and eliminate all outside providers outside of the hospital, because our government is not able to raise the local match. And we would have to, I think, and we think we can do that over years, continually improve our hospital and use our CPE method that doesn't require the match.
We will need to agree with Virgin Island that it is a combination of both. Even though we have more money, if we don't have the local match to be able to comply with the matching funds, we are not doing anything good for the program. So it will be an increase of both relatively. Now, we need to have more money, and we need to have a higher FMAP to be able to do the matching of funds and not to be in the situation that Puerto Rico is facing right now because of trying to cope with the matching of 45%, have taken our island to a financial situation that we are living today with the fiscal board and looking for funds to be able to pay what we get to be able to sustain the program and pay for the matching.
Thank you. Mr. Chairman, and I hope that going forward under your leadership that the consensus, the fact that all the stakeholders are before us, that as we move forward or move legislation, that we seek to continue to promote that consensus. It makes the effort much more powerful, to be honest with you. And so with that, thank you very much again for the hearing. I yield back, sir.
Thank you, Mr. Chairman. I'm going to take the liberty of asking Ms. Muñoz if she could respond, maybe take 30 seconds, 1 minute to respond to Mr. Tonko's question.
What about expanding services? I mean, if you remove the cap, yes, if you remove the cap, you know, there's a lot of opportunities for us to reform our healthcare system. And giving the opportunity to have that predictable funding. You have to have predictable funding and sustainable funding. And if you are able to have those, then you will be able to basically manage the population, bring healthcare reform, bring population health, and have a healthier population for your people. And that's an opportunity for us that we would love to have. Thank you.
Thank you. Thank you very much, everyone. And I just want to let everyone know that we didn't hold this hearing just on our own. We have been working with outside groups. We have been working with Energy and Commerce Committee staff on trying to address this also. We don't want to blindside them. So again, I will emphasize the really important of getting as complete and as concise an answer to those 6 items I gave to you. I also would like, again, I'm really pleased with the Virgin Islands model that they have started. And I know that I understand that some of you have agreed to kick back and on your own, pay your own bill, of course, but at somewhere maybe at Longworth Cafe and sit back and talk a little bit more on how to address on a model so we could put together something for legislation. But I want to thank the witnesses for their truly, truly valuable testimony and many of the members for their questions, their patience. The members of the committee may have some additional questions for our witnesses, and we would ask you to respond to this in writing. Under Committee Rule 3.0, members of the committee must submit witness questions within 3 business days following the hearing, and the hearing record will be held open for 10 business days for these responses. There is no further business. Without objection, the committee stands adjourned.
Thank you.